bones all memorized? Yeah. Medial, lateral, bottom, top.
For the lab spinal, are they open now?
Mm-hmm. That'll be comprehensive, so we need to bring everything you have. Anybody have a copy of that insertion coloring sheet we made last week? I want to show that to people. Are you all done studying it, Tyler?
Yeah.
Okay. Well done. Okay, so for those who weren't here, I'm going to scan this, if you don't mind, and just post it so those who weren't here last Monday will know what to do for the makeup points. So I'm going to ask you about some of these insertion points on the final exam. So you can make that assignment up if you want to help. But I'll give you this sheet, but it has all the answers on it, so I'm going to wait till after the quiz. Give it to you. So we have one more minute.
I'm just going to put it all. It's okay. So are you doing this? Yeah.
Okay, here we are. 2 more weeks, right? Okay. So our first item would be a quiz over your foot bones. So you just need a pen or pencil, and we'll do that for the first 10 minutes. "15 blanks, there is a word bank. You should use every word in the word bank once. Oh, Jackie? done. Great. So as you're finishing, just raise your hand and I'll come by and pick it up. Good job, David. Well done. Great. Got the grade book updated.
Thank you.
Nothing. Good. Everybody else, don't rush. You still have. You just play on your phone if you want to, or just take a nap. Done? Well, that might be all. Okay. Good job. So, it's now who's in need of the assignment from last Monday? Okay. Anyone up? Anybody up? Okay, so Tyler was nice enough to donate his artwork. So what you're doing is labeling insertion points within the foot. The insertion point gives us an idea about what the muscle does, because the location of insertion affects which way the joint rotates. I'm going to email a description, a more complete description, but I will scan and post this on the course under D2L, and then give you some instruction on which slides and which muscles and so on. There's something like 10 points to label, and it's for the purpose of helping you memorize these insertion points and also the action of these muscles for the final, which, let me check on that. Let's check and see when the final is.
It's that Monday from 8 to 9:50.
Oh, okay, so Monday, that's good news, right? 12th? Okay, so Monday, December 12th, 8 to 9:50? Okay, so that'll be in here. I should have a study guide posted probably about this next week at this time. I'll have something posted for you to start reviewing. So my goal today is to finish up with the rest of chapter 10 and then start chapter 11. So we've gone through this good textbook. So plantar fascia is a broad tendinous sheath. So remember, an aponeurosis is different than a cord-like tendon because it attaches over several points. So it's like a sheet. And so the foot gains a lot of elasticity from this sheet on the bottom of the foot. So a lot of your intrinsic muscles of the foot are located just underneath this aponeurosis. So in fact, you have 4 layers of muscles that are intrinsic to the foot that are just proximal to this aponeurosis. So broad tendinous structure extends from the calcaneal tuberosity. So you should all know where that is right now. Also, calcaneal tuberosity is the insertion for the gastrocnemius and soleus. Extends from there all the way to the proximal phalanx of the 4 lesser toes. So remember, all 4 of the lesser toes have a proximal and distal phalanx. So we gain a lot of propulsion. Stabilizes the medial longitudinal arch, and so it has some spring qualities to it. It's also prone to inflammation. People that are on their feet a lot of the time are susceptible to this type of problem where you just have really sore feet from inflammation of this plantar fascia. So that's called plantar fasciitis, is inflammation of the plantar fascia. So here's a picture so you can see all the way from the calcaneal tuberosity on the bottom of the foot, all the way to the proximal phalanx here of these 4 lesser toes. You can kind of see the adductor, abductor hallucis just peeking out here on the medial side, but you have 4 layers of intrinsic muscles that are just proximal to this. So there's a lot of pressure, a lot of blood vessels and nerves that are in this area. So one thing, if you have a occupation where you're on your feet a lot of the time, like a Costco worker, right? You get sore feet. You're in a weight-bearing position all day long. That's really a lot of stress on your feet. So in researching for this chapter, just come up with some strategies. Bottle of water, frozen, seems like a pretty good strategy. Kind of fits that medial arch on the bottom of your foot really well and could provide some relief. So muscles, just like other chapters, the location of the muscles tends to affect their action. So anteriorly, we have the dorsiflexors. So they're pulling up on the top side of the foot. Posteriorly, we have the plantar flexors. So we have two groups of plantar flexors, gastrocnemius and soleus, but we have a whole other group of 4 muscles that are deep to the gastrocnemius and soleus. So lots of plantar flexors. Laterally, we have 2 muscles that act in everting the foot, the peroneus group. And then medially, that's where we have all of our inversion muscles. So the lower leg is divided into 4 compartments. And that's really important because it facilitates return of blood. So your heart puts pressure on the blood, and that's what moves the blood through the arterial circuit. And so once the blood moves through the arteries, through the capillaries, and then onto the veins, there has to be a mechanism in place to get blood back to the heart. Because the blood on the venous side has 0 pressure. So one of the mechanisms is muscle contraction. So having these muscles in compartments facilitates that process of moving blood from the legs back to the heart. So it prevents swelling, especially during exercise. So in the anterior compartment, we have the dorsiflexor group, so the big tibialis anterior muscle. And so we did, for those who had lab this morning, we did an exercise to stretch that one because it's an antagonist to the plantar flexors. Other muscles, we have extensor hallucis longus, as well as the extensor digitorum longus, as well as the peroneus tertius. So the peroneus tertius is a little bit different versus the peroneus longus and brevis. Peroneus longus and brevis are involved with plantar flexion in addition to eversion, whereas the peroneus tertius has its tendon in front of the lateral malleolus, and so it's involved with dorsiflexion rather than plantar flexion. Okay, so the lateral compartment, that's where you have muscles such as the peroneus longus and brevis. Eversion is the primary action, but these muscles also contribute to plantar flexion. Okay, so coming around the back side, we have the superficial posterior compartment. So the gastrocnemius, soleus, and plantaris. We don't talk a lot about the plantaris. It's just a tiny little muscle with a very long tendon that contributes to plantar flexion a little bit. The plantaris is kind of like the palmaris longus, only it's in the leg versus the forearm. It looks a lot like the palmaris longus. So as we look at this, we can see that on the posterior side we have 2 compartments. So we have the superficial posterior compartment. So you can see the gastrocnemius, which has those 2 parts. And then it has a medial and lateral head. And then we can see the soleus underneath the gastrocnemius. It's interesting, the soleus in most people has about 90% slow twitch type fibers. So if you've had your exercise physiology, you know that slow twitch means endurance, right? So it's thought that the soleus is an important stabilizer of the ankle joint. So it has this ability to be fatigue resistant and constantly active, kind of like a lot of the deeper muscles of the torso have that slow twitch characteristic. So the deep posterior compartment, remember TDH, Tom, Dick, Harry muscles from this textbook. Tibialis posterior, which is here. And then the flexor digitorum longus, which is a little more medial, right here. So tibialis posterior, flexor digitorum longus, and then just behind that would be the flexor hallucis longus. In chapter 9, we went over the popliteus, which is a tiny muscle that helps the hamstrings flex the knee joint. The popliteus also externally rotates the knee joint as well, but its included in that deep posterior compartment. You can see the lateral compartment over here, peroneus longus, peroneus brevis, and then all of these muscles, the four muscles of the anterior compartment. So here's a little bit better illustration. So sometimes I go beyond the textbook and try to grab illustrations that are a little more descriptive. So you can see this would be a cross-section of a right leg. No, actually be left leg, excuse me. So a cross-section of the left leg, because you can see the tibia here is on the medial side, and then the fibula is more lateral. So you can see the muscles of the anterior compartment. So this big one that's right up against the tibia is the tibialis anterior. Then you have your extensor hallucis longus and extensor digitorum longus. So then if you go to the lateral side, you have your two peroneal muscles there. So remember peroneus and fibularis, those can be used interchangeably. And then your deep posterior compartment, so you have the tibialis posterior, flexor digitorum longus, and then just right at the back, kind of up against the soleus, you have your flexor hallucis longus. And of course the soleus and the two parts of the gastrocnemius there. So those are the four compartments of the leg. Okay, so chronic injuries are really common. So I would be willing to bet that over 50% of this class, at least at some point, has suffered from what we call shin splints, which is a very non-descriptive condition, collectively called medial tibial stress syndrome. So medial tibial stress syndrome. So right along the medial side of the lower leg, right up against the tibia, where several of those muscles of the deep compartment, as well as the soleus, have their attachment point. So most often involving the tibialis posterior. Okay, so that's right in there up against the tibia in the deep compartment. Flexor digitorum longus, there again, as well as the soleus. So difficult. One of the most important things is progressing your volume. If you're a distance runner, progressing your volume slowly to allow the bones and muscles to adapt to the stress, be strengthened slowly over time. Sometimes strengthening the dorsiflexors also helps. So we have lots of muscles, lots of muscle mass that contributes to plantar flexion, but relatively little that contributes to dorsiflexion. So getting a little more balance there between the plantar flexors and dorsiflexors can sometimes help. I've found, especially because I'm a middle-aged person, that rather than running on flat ground, running up hills helps. Running up hills, your foot is in what position? It's dorsiflexed, right? So you're strengthening the dorsiflexors, plus you can't maybe necessarily run as far or put in as many miles. So running uphill gives you a pretty good workout in addition to helping with any shin splints. So here we see the medial view of the leg. So talking about the flexor digitorum longus. So that's right here. And that's just right there where you get those pains from shin splints. The tibialis posterior is right in there as well. So zeroing in right on that deep posterior compartment. Sometimes it's higher where you'll have the soleus right up in here. So lots of muscles all attached to that shaft of the tibia. Okay, so as usual, bring in a study. So this one was done at the University of Miami, 2002. They looked at the muscles of the lower leg in plantar flexion. So calf raises, right? You've probably done those. Soleus, lateral gastrocnemius, medial gastrocnemius, tibialis anterior. So 3 knee angles. So the knee bent at 90 degrees. So kind of like how many have done seated calf raises? Okay, so yeah. Okay, 135 degrees, which is partially flexed at the knee, and then 180 degrees, which would be like in a standing position. So they really nailed it good on this with 50 repetitions at each of those angles. So here's your summary of results from that study. So let's take a look at the soleus to start off with. Medial gastrocnemius, lateral gastrocnemius, tibialis anterior. So looking at these results for the soleus, okay, so the soleus crosses only the ankle joint. So its primary function is plantar flexing the ankle. So we see that overall the highest activity for the soleus was achieved at that 90-degree angle. So with the knees flexed 90 degrees was where we had the highest activity of the soleus. So, the take-home message might be, okay, so seated calf raises, knees are bent 90 degrees, that's going to target the soleus much more so than the gastrocnemius. So you look at the results for the gastrocnemius, lateral gastrocnemius, medial gastrocnemius, and the highest activity levels were evident for the knees fully extended at 180 degrees. So you can see there the clear bars, especially for the medial gastrocnemius. I'm not sure if they had a toe out or toe in position or just in a neutral position. There's probably some other research that's looked at that, but they didn't specify in this particular study. Okay, so now we come to the neural innervation, your favorite part, right? Okay, so what do you need to know for the final exam? You need to know everything between this line and this line right here. Okay, so for this chapter, chapter 10, muscle neural innervations, you need to know everything from here down to right here. So nothing below this line, nothing above this line. This line is all chapter 9. So I will ask you about chapter 9, but for chapter 10, everything from here to here, just this section right here. It's really not that bad because it's just one nerve. It's the sciatic nerve, and how many divisions does the sciatic nerve have? It has 2. So if you want to memorize this in conjunction with your compartments, that's a really easy way to do that because everything in the deep and superficial posterior compartments is the tibial branch of the sciatic nerve. So you've got your plantaris, both heads of the gastrocnemius, the soleus, and the popliteus. So that's your superficial posterior compartment. Deep posterior compartment, it's still the tibial branch of the sciatic nerve. You've got flexor digitorum longus, flexor hallucis longus, and tibialis posterior. Right there. Okay, so basically, superficial and deep posterior compartment muscles is the tibial nerve. Plantaris is also part of that deep compartment that I left out there. So that's still a tibial nerve. So then your anterior and lateral compartments, okay, that's the common fibular branch of the sciatic nerve. So that's everything over here. So your anterior compartment, right, that's tibialis anterior, extensor hallucis longus, extensor digitorum longus, peroneus or fibularis, okay, that's the other word for peroneus, tertius, and then you have your lateral compartment, which is your fibularis or peroneus longus and brevis right here. That makes it a lot easier. Just know your compartments, and then you can tie in which of those branches goes where. So do you have any questions on that part? Yes?
Do you have a preference of fibularis versus peroneus?
Nope. No, up to you. Whatever one you have, you can remember better is fine. Okay, so gastrocnemius. So let's go back. Why is it that seated calf raises place emphasis on the soleus? So you see people, and they can really load up that seated calf raise machine. You see that with the seat. They have their knees flexed, and you have the pads over the knees. Knees are bent, and you have your toes on that underneath the pad there on that surface, and then you have that pin, and you can really load it up. We take the gastrocnemius out of that movement, primarily because the gastrocnemius is also a knee flexor. So what do we know about muscles that cross two joints? They can do one action at one joint or the other action at the other joint, but not both to the greatest extent at the same time. So if we're in a seated calf machine, we are flexed at the knee already, and at the same time we're plantar flexing at the ankle. So the issue is that active insufficiency that we talked about. So the gastrocnemius is actively insufficient during a seated calf raise. So that's the reason why. So the gastrocnemius does contribute a lot to flexion of the knee joint. So it's a synergist for the hamstrings. Soleus doesn't cross the knee joint, so its only action would be plantar flexion. Has insertion points up here on the fibular head, as well as just distal to the proximal tibia and down the shaft a little ways, and then combining down here with the gastrocnemius at the calcaneal tuberosity. Okay, peroneus longus. I want you to notice the tendon on this muscle, how it works. So the peroneus longus drops behind the lateral malleolus, and then it goes underneath the foot. So this is the lateral side, this is the medial side of the foot. So it passes behind this lateral malleolus and then goes underneath the foot and actually inserts on the undersurface of the foot on the medial side. So talking about the base of the first metatarsal as well as the medial cuneiform. So this muscle is going to pull in this direction. It's going to pull in this direction. So in other words, it's going to turn, if it's pulling up this way, it's going to turn the foot into eversion, turns the sole of the foot out. Peroneus brevis is not quite so long on the tendon. It has its insertion here at the styloid process, sometimes called the tuberosity of the fifth metatarsal. So it's that bony prominence there on the lateral side of the foot. This muscle also passes behind the lateral malleolus. So remember, the malleoli serve as pulleys. So it gives that those two muscles a mechanical advantage. Okay, peroneus tertius. This is a little bit different versus the other two peroneal muscles, because now we're passing in front of the lateral malleolus. So because of that, it contributes to dorsiflexion, but it also has its insertion here at this styloid process of the fifth metatarsal. So it's going to turn the foot out as well. Okay, extensor digitorum longus. Okay, so on the front side, top of the foot, this one has tendons that are concerned with the four lesser toes. So kind of like the extensor digitorum you had for your hand. It's very similar. Okay, so this muscle splits just after the ankle joint. You can see the tendon splits into four different parts. Goes all the way down to the middle and distal phalanx. So it acts on the ankle joint, but it also acts on all of these joints all the way down to the tips of the toes. So the interphalangeal joints, the metatarsophalangeal joints, the ankle joint itself. So it's a muscle that has action at a large number of joints. Okay, extensor hallucis. So a good question on the final, just like exam 3. What term is used to for muscles that have action on the great toe? So then you would say hallucis, kind of like pollices was one of the questions on the last exam. So you can see this one has its origin here on the shaft of the fibula. So this would be a right leg, anterior view of the right leg, and then comes over to the medial side, so past the medial cuneiform, past the first metatarsophalangeal joint, and inserts down here just past the interphalangeal joint of the great toe. So basically extension. So you're sitting there in your shoes and go ahead and just extend your great toe there, and that's, so as tonight as you take your shoes off, you're looking at your feet, extend your great toe. This tendon is really prominent with that action. You can see it really well. Okay, so tibialis anterior, that's the largest of the dorsiflexors. It's just this big massive muscle on the front side of the foot there. The reason it's called the tibialis is it has most of its mass attached to the lateral side of the shaft of tibia, and then comes down right here at the medial cuneiform and base of the first metatarsal is where we have our insertion point. So I thought I would have some fun with this presentation. So I'll bet some of you didn't know there's actually a plate-loaded dorsiflexor machine made by Hammer Strength. So what you do is you put your foot right here underneath the pads, you're putting your toe underneath the pad, and then you're just doing loaded dorsiflexion. You got your plates on each side, and I've actually had the opportunity twice to work on one of these machines at just different gyms that I've been to. But it works really well. If you think of all the different ways people have tried over the years to effectively target the dorsiflexors, most people I know don't really worry too much about dorsiflexors, but you're gonna get a lot of imbalance there especially if you're always pushing off your toes. That's plantar flexion, but those muscles on the anterior side are going to get neglected, right? So I've seen people put their toes under a couch and try to effectively do that. There's some other ideas here that I came across. So this seems like it'd be pretty reasonable, right? So just a elastic band, and but if you have the money, and I'm sure that I don't know how much that costs, probably a lot, probably way overpriced, but it seems like a pretty good idea. So let's go around the posterior side. Tibialis posterior is going to be in the deep compartment. So we're looking at the posterior side of the leg here. This would be a left leg, where you can see right between the shaft of the tibia as well as the shaft of the fibula there. And then dropping down, remember there's 3 muscles that are directly behind the medial malleolus. So tibialis posterior, flexor hallucis longus, flexor digitorum longus. So those 3, they all utilize this medial malleolus like a pulley. So you're increasing that moment arm because of the malleolus. So that's leverage, that's torque. So this muscle drops down behind the medial malleolus and then actually drifts laterally. So it's drifting over more to the outside of the foot, kind of towards the 2nd, 3rd, and 4th metatarsals. So it also attaches to the medial, intermediate, lateral cuneiform, as well as the cuboid, navicular, and calcaneus. So that's pretty broad. So just a big mass of tendons attached to just about every bone underneath the foot. So flexor digitorum, kind of the same type of structure. Flexor digitorum, right? Flexor of the toes or digits for the foot. Going all the way down to just the proximal phalanx. Well, I take that back. That's the distal phalanx here. So it has action in plantar flexion, but also all the way across the metatarsophalangeal, proximal interphalangeal, and distal interphalangeal of the foot. And then flexor hallucis. So that's the third behind the medial malleolus. So more good test questions, right? 3 behind the medial malleolus, 2 behind the lateral malleolus. Okay. So this one goes all the way down to just past the interphalangeal joint of the great toe. So you can flex that interphalangeal joint of the great toe, and that's the muscle that does that. Okay, so intrinsic muscles of the foot. Okay, so to be honest, on the final, there's a lot of other stuff I want you to focus on, so I'm not going to ask you questions about the intrinsic muscles of the foot like I did with the hand. Okay, but I'm still presenting the information, but this won't be emphasized on the final, so just so you know. So the top of the foot, sometimes called the dorsum of the foot, we have 2 muscles, extensor digitorum brevis and extensor hallucis brevis. So if we, forgot to highlight them there. So tendon of extensor hallucis brevis is right here. It's that little tendon there that goes down into the great toe. And then we have extensor digitorum brevis, some tendons for that muscle there. For the second, third, and fourth of the 4 lesser toes. Okay, so as noted here, the remainder of the intrinsic muscles are in 4 layers on the plantar surface. So plantar surface, right, that's the bottom of the foot. So we have just underneath the plantar fascia, we have this first superficial layer. So I'm just going to highlight these in red. So adductor hallucis, flexor digitorum brevis, abductor digiti minimi. So you can try this as you're sitting there with your feet. Can you abduct as you're sitting there? Can you abduct your 5th toe? Can you try that? The abductor digiti minimi kind of pulls that, right here, pulls that 5th toe away. So you can try some of these actions that affect these muscles. Second layer, noted in green. Okay, so that's the quadratus plantae. It's right here. And then the lumbricals. So remember lumbricals from the hand? We also have those for the foot. So that's the first 2. We have the 3rd and 4th layer. So flexor hallucis brevis, adductor hallucis, and flexor digiti minimi. So that's not shown. And then the deepest layer, this would be the one closest to the bones of the foot. Dorsal interossei, there's 4. How many do we have for the hand? We have 4, right, for the hand. And then the plantar interossei, how many was there for the hand? There was 3, so it's very, very similar. So the dorsal interossei would be involved with spreading the toes out at the metatarsophalangeal joints. Plantar interossei would pull the toes back together at the metatarsophalangeal joints. All right, so end of chapter 10. Do you have any questions? Okay, all right. Can I do a little of chapter 11? All right, we're going to do a little more, and then we'll call it a day. So let me just.
So much room.
All right, so trunk and spinal column. So we've gone all the way down the upper extremity, all the way down the lower extremity. Now we're doing everything in the middle. Okay, so chapter 12 is on movement analysis, and you've been doing that all through the semester. So, okay, so chapter 11, trunk and spinal column. So the vertebral column is made up of 24 movable vertebrae. So these are motion segments. The vertebrae can move in all three planes of motion. So sagittal, frontal, and transverse. We have that capability. So we'll talk about joints that enable us movement between vertebrae. So we also have some non-movable vertebrae. There are actually 33 total. So 24 of them are movable. So this, the 7 cervical, 12 lumbar, or 12 thoracic, and 5 lumbars. That's 24. The non-movable ones include the 5 sacral. Okay, they're fused together, and then the 4 coccygeal would make up the total of 33. So we have 31 pairs of spinal nerves. So these are all mixed. So does anybody from maybe Carl's class remember what mixed means? Yep, I think you both had it. So there's 2 types of nerve cells, sensory and motor. So sensory brings signals into the spinal cord. Motor takes signals back out to elicit responses. So the 31 pairs have both sensory and motor functions. Okay, so, and then the abdominal muscles. One of the unique features of this part of the body, the abdominal muscles connect to each other. So far we've talked about origin and insertion points, so attachment points on the skeleton, but one of the unique features of the abdominal muscles is they connect to each other as well as to the skeleton. So it's kind of like a highway system. So you have your lower body and you have your upper body, and then you have this bridge across the middle. And so that's all these muscles here that provide the bridge between the legs and the arms. Okay, so 24 articulating and 9 fused, so 33 altogether. Count them up. So notice that the spine has normal curves. Okay, so you have the thoracic and the lumbar, which are curved posteriorly. And then you have the thoracic and sacral that are curved anteriorly. So it's the curves that enable effective load bearing. So we want some curvature, but not excessive curvature. So very important how we design an exercise program. If people have lots of movement just due to their occupation, where they're doing one action all the time, it's very important that we do opposing actions so that we have balance in muscle development. So the first 2 cervical vertebrae called the atlas and the axis, so C1 and C2 respectively. The vertebrae overall increase in size from the cervical down through the lumbar because as we progressively go down the body, we're supporting a greater portion of our body weight. So that makes sense. Other than C1 and C2, C3 through L5 have a very similar structure. They have some unique features, but some things that are very similar. So there's the anterior part, so it's kind of looks like a block. And then the cervical vertebral foramen, central vertebral foramen for the spinal cord, so that's this part right here. The transverse processes that project laterally, so here and here. Okay, so that's important for muscle attachment. And then the spinous process that projects posteriorly, so also very important for muscle attachment. So here's an example of the second lumbar vertebrae with the anterior body, posterior spinous process, central canal, and then a transverse process on each side. You'll notice that vertebrae also have these articulating facets. So this is called a superior articular process. So that's the way the vertebrae fit together, is through the disc, which sits right here on the body, but also these articulating facets. So there's one below and one above that connect to the vertebrae above and below. Okay, so here's how the spinal cord fits into all of that. The spinal cord, including the brain, surrounded by 3 layers of connective tissue. So you can see here, closest to the brain and spinal cord is this layer, right here, the pia mater. The next layer out is the arachnoid mater, and then the dura mater. So there's those 3 layers that have a protective role with the brain and spinal cord. You can see that as the vertebrae fit together, there's a space for exit of these spinal nerves. And so 31 pairs of spinal nerves that project on each side and have sensory and motor functions. Okay, so the atlas and the axis. So the atlas is the first cervical. It has 2 articulating facets for the occipital condyles of the skull. So if you look at the bottom of the skull, there's these 2 facets where the atlas articulates. So we call that the atlanto-occipital joint. Atlanto-occipital joint is between the skull and the first cervical. The axis is the second cervical, so it articulates or connects with the atlas. So one of the unique features of the axis is that it has this pivot process called a dens. And so the atlas pivots around this dens, this pivot point. The atlas will rotate. So it's called the atlanto-occipital joint, or called the atlanto-axial joint, atlanto-axial joint. Okay, so the atlanto-occipital joint you can see here. So it's classified as condyloid. So another really good test question, condyloid. So condyloid means how many planes? Yeah, 2. So that's the only one that has 2. They're either uniplanar or multiplanar. There's condyloid that's the one that's 2. So what we get is flexion of the head and extension of the heads. Okay, so that's sagittal, right? But we also get lateral flexion. Lateral flexion. What plane would lateral flexion be? Yeah, frontal plane movement. So those frontal and sagittal action happens at the atlanto-occipital joint. The atlanto-axial joints. Remember how I talked about how the atlas pivots on the axis? So you can see here the dens from the axis that provides this pivot point for the atlas on top. So there's even this ligament from the first cervical vertebrae that stabilizes the dens. So you have this nice stable pivot point. So the atlanto-axial joint is considered to be trochoid or pivot type joint. So this would be where you have rotation. So rotation of the head, which would be transverse plane, right? Transverse plane. Okay, so I want you to learn a few distinguishing features for the vertebrae. So this is things you might write down in your notes. Cervical vertebrae. So 2 things about cervical vertebrae that are unique. First one is they have what's called a bifid or a split in the spinous process. So you can see that here, this split in the spinous process. So if you look at all C3 through C7, there's this split. That's important because that's an attachment for an important ligament of the neck that holds the head up. It's called the ligamentum nucha, or nuca, and that attaches within that notch. and that's how you keep your head up. The other distinguishing feature are the holes in the transverse process. So the transverse foramen has these holes. The transverse process has these holes called the transverse foramen. And so that's important for passage of blood vessels. So here's an illustrated drawing, again pulling from material external to the textbook, but you can see the holes, the transverse foramen through which the vertebral artery passes. The vertebral artery is a branch of the subclavian down here. So the vertebral artery passes right up through those transverse foramen. So it supplies the head with blood. Okay, so thoracic vertebrae, two distinguishing features. First one, we have these costal facets, superior and transverse costal facets. So these facets allow for attachment of the ribs. Okay, so 12 thoracic vertebrae, 12 pairs of ribs, all the ribs taper around and have two attachment points on each side of these thoracic vertebrae. So costal facets. The other one that you can tell, for a thoracic vertebrae, the spinous process projects downward, as you can see here, which is different than the cervical and lumbar. So again, costal facets and then downward projecting spinous process. Okay, lumbar vertebrae, two distinguishing features. First one, the large body, very thick body designed for weight bearing. The second one, they have very thick transverse and spinous processes, and that's for designed for muscle attachment. So the body and then the thicker transverse and spinous process. So there's a lot of small intrinsic muscles in this area that are too deep to palpate. We're going to go over the most important ones involved with movement. So the best thing would be just to use your study guide to get an idea of which muscles you need to know and the actions. A lot of these muscles are very rich in proprioceptors. So remember we talked about muscle spindles, Golgi tendon organs. Muscle spindles respond to stretch. That would be important with the spinal column because you want it to be stable. So as an example, muscles like what you see here have a very high density of muscle spindles. So these muscles attach to adjacent vertebrae. They're very small and have lots of sections. So for example, the intertransversarii runs all the way from the top of the spine down to the bottom, and you have these sections that run between adjacent transverse processes. Same thing for the interspinalis here. So the interspinalis, you have sections that run between adjacent spinous processes. Okay? So that's stability from the back, stability from the sides, and then you have a lot of rotary stability as well. So looking at the rotatorus, okay, so that stabilizes the spine against rotary type torque. So if you look at these sections here, you have a section here that connects the superior articulating facet of the vertebrae below with the spinous process of the vertebrae above. So you have this little fascicle, this bundle of muscle cells that connects these two adjacent vertebrae. So you also have this one right here that connects the superior articulating facet with the spinous process of the vertebrae that's 1, 2 above there. So other muscles, the multifidus runs all the way up and down the spine. So all of these muscles have a specific function in keeping the vertebrae in the right position. Because if you have a vertebrae that slips too far, you've got pressure on those spinal nerves, right? Okay, that causes loss of function in those muscles that are innervated by those muscles. So we have to have this spine stay in just the right position. So very, very important that we have these muscles that act as stabilizers. So we could say they're core stabilizers because they have these muscle spindles that keep the vertebrae in the right alignment. Okay, so we have 12 pairs of ribs. Okay, the first 7 are true ribs because they attach directly to the sternum. So they're considered amphiarthrodial type joints. So 1, 2, 3, 4, 5, 6, 7. So right here, these first 7 are true ribs, and these joints are made of cartilage. Okay, so we have to have just a little bit of flexibility in the rib cage. So as we breathe in and out, the rib cage expands and then retracts. And so these ribs not only facilitate breathing, but they also facilitate shock absorption. So there's a little bit of give in the rib cage to protect your heart and lungs from impact. 5 pairs of false ribs. So 3 of these attach indirectly to the sternum, and then 2 pairs are considered floating ribs. So you can see these 2 pairs, 11 and 12, on each side that have a connection to the 11th and 12th thoracic, but they have no anterior connection to the sternum. And so you can just see how on the posterior side, each rib kind of pivots in, and that's where you have that connection between the transverse and then the superior costal facets. So here and here is where you have those connections. Okay, so there's minimal movement between any 2 vertebrae. Okay, so except at the atlantoaxial joints. Remember, that's where we have rotation of the head. So if you look at the connections between the vertebrae, so you have these inferior and superior articulating facets right here, all the way up and down the spine, another one right here. So that's where you have all the movement taking place. So it's the cumulative effect of combined movement across several of these facets that enables substantial movement to occur. So it's different than other joints like the shoulder or the elbow or the knee where it's just one joint. So if I'm doing this with my spine, or if I'm doing this with my spine, or this with my spine, okay, it's not just one joint, it's all these joints where we have just a little bit of movement taking place that allows for the large gross movement to occur. So these facets, example here and example here, these are arthrodial or gliding type of joints. So another good test question there, arthrodial or gliding with the facet articulations. Okay, just a couple more slides, we're almost there. Okay, so joints between the vertebral bodies, C2 to S1. Okay, so you not only have the facets on each side, but you also have these discs between the bodies of the vertebrae. So these discs have 2 parts. So you can see that each disc has this fibrous outer part called the annulus fibrosus, and then this inner part called the nucleus pulposus. So the nucleus pulposus is has a gelatinous type consistency. So how many of you, by the show of hands, you had your turkey, put it in the fridge, leftovers, you get it out the next day, and what does it have? Have you noticed kind of that gelatin type substance that's on some of it? Maybe? No? Yeah. Okay. All right. Poor analogy, never mind. That's what the nucleus pulposus is like. So it kind of acts as like a liquid ball bearing that allows the vertebrae to kind of have just a little bit of flexibility. So not like a diarthrodial joint, but just a little bit of movement. So these are classified as amphiarthrodial. Okay, so the outer part is the annulus. The inner part is the nucleus. Okay, now if we actually go above the disc and below the vertebrae, we have something else. Okay, so bear with me on this. So we have the intervertebral disc. Below that, we have this end plate that's made of cartilage. Okay, so that's underneath, and then underneath that, we have this body of the vertebrae. Okay. Now, people can have what we call compression fractures. How many have heard of a compression fracture? Okay, so what can happen in that case is we actually get fracture of this end plate. Okay, and what can actually happen is the nucleus in the middle of the disc can migrate. Remember, it's kind of a liquidy, gelatiny type substance. It can migrate through the fracture and actually down into the spongy bone of the body below it. Okay, so that's going to reduce the disc height, right? Because it's this gelatin inside the disc that gives the disc its height. So if you have shrinkage of the disc, okay, that's going to give the nerve root a lot less room, and so you're going to get pinching of that nerve. So that's one way that we can have these herniated discs. So a herniated disc simply means that we have this nucleus pulposus that's migrating through this annulus, or in the case of what I just shared with you, it can migrate through this cartilaginous end plate. So it can migrate through here if there's a fracture here in this end plate. And so it gets down into this, either the spongy bone down beneath, or it can migrate out here and put pressure on these nerve roots. So over time that can create a problem, a lot of loss of pain, or pain, numbness, tingling, weakness in those muscles, because those muscles are innervated by these spinal nerves. So in order for a muscle to stay healthy, it has to have that neural connection. So all the more reason why having good muscular endurance in these muscles that surround the torso is so important. So 4 out of every 5 people will have back pain at some point in their lives. And back pain has been connected with a lack of endurance in muscles more so than a lack of strength. So you think about that. The definition of strength is how many lifts? 1 lift, right? As much force or torque for 1 lift. What's the definition of muscular endurance? Yeah, submaximal force or torque over an extended period of time or for an extended number of repetitions. So really important, all of these muscles around this area that we're going to talk about in this chapter, if we can get better muscular endurance, better fatigue resistance, then even if we have problems like this, we're going to be less likely to experience these symptoms because we've got the muscles that are compensating for failure of these passive tissues. So we'll talk about those muscles on Wednesday. So really appreciate it. Thank you. So we'll end right there for today.